So, in conclusion to the previous discussion about basics and interpretation of quad map in Pentacam, so today I'll be focusing on a few more useful maps to look at in the clinics among the numerous maps which are seen here in the drop-down menu with one click. So other than maps I described today, the rest of the maps as seen here, or which are permutations and combinations of axial, tangential, pachymetry, anterior and posterior float maps, similar to quad map. So these are the maps we'll be knowing in detail about today. 3D overview display, fast screening report, bad map, glaucoma screening, corneal densitometry map, holiday and EKR detailed report, cataract pre-op display, customized IOL calculation, and aberrations, corneal aberrations report, iris image in roll in phakic IOL, and contact lens fitting using Pentacam. So immediately after opening the Pentacam, the default display which appears before us is the overview display, where we can see the 3D images of the captured segments of virtual eye and shine plug images and other info. So here we have to focus on the shine plug images and quality specification, which is QS, to assess the quality of the scan first. So all shine plug images should be checked to rule out any presence of artifacts like reflections from slit light or if the camera lens is dirty. And also centration should also be checked. So focus on the QS symbol. If the QS symbol QS is okay, then there is no need to repeat the scan. But if it's red, then click on the QS button. The following dialog box appears, and we have to check the reasons for the faults. So if the notes displays that all these things in it, then it gives details of the errors like inadequate corneal exposure, frequent blinking, no shadow or head or eye movement, and also alignment issue, and also about signal to noise ratio problems. So then we can repeat the scan, correcting the error which is indicated here. So next is about the fast screening report. This report is a very good way of quick overview when examining patients, especially when they're presenting for the first time. So here, all the relevant data is compared with the normative data of a normal population, and they're converted to index values using suitable algorithms. These index values can help us know about the underlying pathologies in the anterior segment. So so here the distribution black line to the right, as we can see the black line, which indicates the value of the current patient, and its position in the bar chart shows where it comes to line the standard normal distribution. Gray part, the light gray part, it represents one standard deviation from normal, and the dark gray part to the extremes indicates two standard deviation from the normal population. So to the left, we can see the red and green chart. This is a normal distribution. Green is a normal distribution and red shows the pathological group. So moving on to bad display, which is called Belin Ambrosio Enhanced Ectasia Display. Here,
Tulasi, can I interrupt you for a moment? I was just thinking if we can just go back to the previous one, and if you can tell us about this particular, like the one which you were showing, or for that matter, example, on this one first, and then on each of them, like for this particular patient, was it normal or abnormal, and what was the significance? I mean, a small discussion on that if we can just have. For example, here the black bar is in the red over here. So what does that signify?
So if the black bar falls to the red side, it indicates that the patient has two standard deviation values like away from the normal population. That is, the value is abnormal.
So what if
so
it was,
in the right,
it was at the extreme right gray zone? What would it have been? Would it have, then where would have this black bar been over here?
So if the bar lies in the, when you look at the bar diagram, if the black line lies to the extreme right or left side, dark gray zones, it indicates that the value is abnormal and it is away from the normal population by two standard deviations. If it is in light gray, then it indicates
No,
that
I
it is
understood that.
also abnormal, but it's kind of borderline, which is one standard deviation away from the normal population.
I already understand that.
Yes.
What I'm trying to ask you is that right now your black bar is on the extreme left dark gray zone.
Left.
If it
Yes.
was on the extreme right dark gray zone, what would it signify? Instead of being on the extreme left dark gray zone, if it was 2 standard deviations to the other side, what would it signify? I know it would be abnormal, but what would it mean? Like, because it would be probably at the beyond the green zone, right?
Actually, sir, left to the left, these are the to the left values are to the minimum, to the extreme right values are to the maximum. The patient, let's say, if the patient has anterior chamber depth of which is very low, so which is very low from the normal
Hmm.
population, it goes to the extreme left side. If it is very high, if the chamber depth is too high, then it goes to the extreme right side, sir.
Hmm. So this particular one map which you have zoomed in, is it for what parameter is this?
This is in general to I mean highlight about what is red and what is green. So here we can see
No,
in
but
this
what is
report.
24.4 and what is 23.7?
Okay, so in this, like as we can see, each individual parameters like antechamber angle,
Exactly.
antechamber depth, and volume. So for each parameter, there are different values which is indicated here. For example, in the left, as we can see, pachymetry minimum, they're giving 449 and 545 as numbers. So for each parameter, the values varies according to the parameter which is mentioned.
Right. So now let me just kind of intervene here, and let's see the number two thing on the left side. That's the Paki, right? The
Yes,
minimum Paki on the left
yes.
side. So now if you look at that, and I don't know if my pointer is working. Let me see if I can use a pointer here. I don't know if I can, but anyway, if I probably can't. But if you notice, it's a 600 Paki. So it's in the gray zone, which is on the right side. Okay. And if you notice the same corresponding thing on the green map, it is on the right side, which means it's on the green thing itself. Had it gone into the dark gray zone on the extreme right, it would have been even big, thicker Paki, like maybe 674 or more than that. Right?
Yeah.
So it would probably even go out of that green zone. But it would be again abnormal, as you said. Now, the only thing is that this map may be a little fallacious because, even, it is assuming that what is, for example, for pachymetry, it is assuming that a very thick pachy is green, which is not necessarily right, isn't it? I mean, it's labeling it as green because it would appear in this green part of the map, right? Because even the
Green part,
600 is
yes.
actually appearing in that,
Yes, sir.
right?
So what
So
I
I'm just
understood is
thinking
like
like,
in the green
yeah,
part also it is actually showing to the extremes of the curve. So if it is going beyond and
right.
falling into the dark gray zone, then the line would definitely fall into the red because as we can see to the left bottom elevation back where the 23.8 value is to the extreme right. So the black line,
Hmm.
I mean, it is indicated in the red curve again there.
Right. Okay. So I think this is a very useful map for quickly checking if anything is falling in the red or the green, and then focusing maybe on those which are falling in the red to see whether, they're abnormal, and that will give you an idea which map to look up further, I think, isn't it? So I think it's a useful thing because it gives so much information only on one map. So I think we should make a habit of actually looking at this for 2 minutes. We don't normally look at this, but let's start looking at this map more often. Anything, Dr. Ruchika? Like, I mean, would you like to comment anything on this particular fast? Because we don't normally use this fast screening much, but if you think that it adds value to your this thing.
No, sir, even I really don't pay much attention to these maps.
But I think maybe let's start using it and see if it like becomes useful to us. We'll know within few days, right? So,
Right.
okay, let's go ahead.
So here, firstly, like we can see that these are three different corneas: normal, mild, keratoconus, and advanced, which looks alike in this picture because the reference surface is not used to compare them. So this shows that importance of using appropriate reference surface to highlight the abnormalities in the cornea. So what is this reference surface and importance of it? So without a reference surface, raw elevation data, which is produced by Pentacam from normal eyes, they look similar to abnormal eyes by subtracting the elevation data when comparing it to a shape like a best fit sphere or best fit toric ellipsoid, which is called BFS and BFT, the differences become highlighted or exaggerated as seen in this picture. Here this is the anterior elevation map of the patient with keratoconus. So here we can see the central island of elevation, which is clearly visible here, indicating the numbers of plus 27, 30, and 20. So it corresponds to the location of the cone. This is visible only when the raw data is compared to the reference surface. Uh, but sometimes in early ectasias, the regular reference surfaces like BFS and BFT, they doesn't highlight much of the early keratoconus or form fresh keratoconus. So enhanced reference shape is introduced. This concept is introduced to detect early ectasias. So this enhanced reference surface is designed by Pentacam software based on the individual's own cornea after excluding the conical or ectatic region, which is 4 optical zone, which is centered on the thinnest portion of the cornea, as you can see to the right, generating a new enhanced BFS by utilizing all the data from 8 central cornea without the exclusion zone, which I'll be describing it in detail. So here in this image to the left is a elevation map of the patient with keratoconus, and it shows a large area of abnormal elevation. And to the right, we can see there is a red circle here, which is excluded, which is the area which is to be excluded from the calculation, which is 4 optical zone, which usually is centered on the thinnest portion of the cornea. So now let's see interpretation of the bad display in detail. So here, when we divide the map into two halves, to the left half, we can see that the elevation data is completely shown in detail. So the first two elevation maps above, they're called standard elevation maps. These are nothing but the baseline relative elevation of the cornea using a best fit sphere, BFS. So this map is displayed for the front surface to the left and back surface to the right of the upper part. So the radius of the values here to the above, as you can see, the radius of curvature of the BFS is indicated in millimeters, and the diameter of the zone is indicated in millimeters. So below that, we have anterior and posterior elevation exclusion maps. So in these maps, the BFS is calculated using all the raw elevation data as I described earlier, excluding the 4 zone, which is centered on the thinnest point of the cornea. So bottom two maps are the difference elevation maps. They show the relative change in the elevation from the standard elevation map above to the exclusion map in the middle. So this is the difference between the above two maps. They are basically represented on three color scales, showing the amount of elevation change that occurs when moving from baseline elevation map to exclusion map. So when you see green on the difference map, it represents elevation of 6 microns of the front surface or 8 microns on the back surface of the cornea to the left and the right respectively. And if you see yellow areas, it indicates the values of 6 to 12 microns for the front surface and 8 to 20 microns for the back surface, which is nothing but a suspect cornea. So when you see red, for the anterior, if it's greater than 12 microns and posterior greater than 20 microns, so it indicates that it is a known case of keratoconus. So now moving on to the right half, we have pachymetry display, which includes pachymetry map to the right extreme above, and two graphs below, which are CTSP called corneal thickness spatial profile and PTI, percentage thickness increase, to the bottom. Basically, this the pachymetry display identifies the corneal thickness at the apex especially, and also at the thinnest point. What is the CTSP? Corneal thickness spatial profile. It is a measure around 22 imaginary concentric circles with 0.4 steps, which is centered on the thinnest point only. This is nothing but it indicates the progressive thickening of the cornea from thinnest point to the periphery, which is plotted on a graph as seen here. And percentage thickness increase to the bottom here, as you can see, is the percentage of progression of the thickness from the thinnest point of the cornea to the periphery. It is nothing but the percentage representation of the CTSP map. So in other words, we can say it is the ratio of mean corneal thickness minus the thinnest point divided by the thinnest point. So, and to the bottom, we can see 5 differential parameters, that is D values at the bottom. So DA is nothing but anterior elevation from standard to enhanced reference surface. And DB is changes in the posterior elevation to the enhanced reference surface. And DT is the corneal thickness at the thinnest point. And DP is pachymetric progression. And all these 5 differential parameters, they are summed up and uh, compared to linear regression analysis, and the value is generated out of all the parameters. These are again color coded. If the color is shown as white, then it indicates that the standard deviation is less than 1.6. If it's more than 1.6, it's indicated in yellow, and if it's more than 2.6, it's indicated in red. So in addition, we have a BAT3 display where other parameters like Kmax and anterior posterior elevation of the thinnest point and ART max are included. So ART max is nothing but the ratio between the thickest point and the percentage pachymetric progression index. Again, we have to know about PPI, which is pachymetric progression index. This is nothing but the corneal thickness covering the 360 degrees area of the cornea. So ART max is the ratio between the thinnest point, PP, and pachymetric progression index. The importance of this knowing this ART max is it is a diagnostic, one of the diagnostic index which distinguishes from the keratochronic eyes from the normal eyes, but it doesn't have much role in identifying form first keratoconus. So moving on to glaucoma screening, 3D model of the anterior segment, which is created by Pentacam in itself, it estimates all these parameters like anterior chamber angle, anterior chamber depth, which is very useful in assessing and monitoring cases of the glaucoma, especially in primary angle closure glaucoma. It also gives cornea. It also compares the pre-op and post-op comparison of change in parameters after laser iridotomy. And also in glaucoma screening report, we can generate a corrected IOP by entering the normal IOP, measured IOP, and pachymetry values. So that the machine automatically generates by taking in these values, giving us the corrected IOP by using its algorithms. So thus in a single scan in glaucoma screening, it is helpful in objectively tracking the glaucoma progression along with the HFA, and it is great in educating the patient about the condition. So this feature is mainly present in Pentacam AXL, and also densitometry feature is present in Pentacam AXL, which is better described in Pentacam AXL. So densitometry is nothing but to assess the density of the specific layer in the anterior segment. This feature is helpful mainly in detecting the corneal pathologies, like Fuchs dystrophy and pre-op and post-op comparison of the laser treatments and corneal surgeries, and also very useful in showing and explaining patients about the corneal transparency in the scars. So this is how the report looks like. And in refractive surgery, it is helpful in following up the corneal haze patients after refractive surgery. And also, but the disadvantage of this is if the cornea is very hazy, the scatter will be too high such that the measurements are unreliable. So next, moving on to cataract pre-op evaluation. To perform a better cataract surgery, going through all these reports at a time helps surgeon to plan better and have good visual outcome, especially when planning for premium IOLs. So in fast screening report, quickly we can look at if there are any presence of angle closure or risk of glaucoma. And we can detect any corneal scars or presence of any early Fuchs dystrophy in corneal densitometry. And we can assess the cataract density with the blue light illumination, and also quantify the lens opacification, which is called PNS nuclear staging. So here, that's how this report helps a surgeon to plan phaco accordingly and use ultrasonic energy in an optimized way, and also helps to educate patients about the intensity, grade of cataract and its progression. So, moving on to premium IOL selection, which can be done in 4 easy steps using Pentacam. First step is to evaluate the corneal irregularities. Second step is to see the corneal shape. And third step is to evaluate the corneal spherical aberrations. And fourth is to evaluate the corneal astigmatism. So in step one, as I said, like we have to assess the corneal irregularities, which are nothing but the higher order aberrations. So as we can see to the right side, if the higher order aberrations are greater than 0.3, then multifocal IOL is generally not indicated due to poor quality of the image which is generated post-operatively. And also look at the angle kappa and angle alpha. So if the values exceed more than 0.4 mm, then centration of toric or multifocal IOL especially would be a problem. So it's better to defer multifocal IOL implantation if the angles are too high. And step two is to look at the corneal shape. If the corneal shape is regular, then it indicates that the patient is suitable for toric IOL implantation. And third step is to look for spherical aberration, which we often miss in our day-to-day practice. If the value is more than 0.1, um, then as we can see, there is a decision tree to decide which IOL to be implanted to the patient. If the angle kappa is high, then always choose a spherical IOL with zero spherical aberration. And if the angle kappa is normal or low, depending on the occupation of the patient, if the patient is a night driver, then he requires more depth of field. So it's better to go for a spherical IOL with zero spherical aberration. And if the image quality is critical to the patient, then go for a spherical IOL with negative spherical aberration. And in prior, like a patient, if the patient had prior refractive surgery, if it's a myopic LASIK, then go for a spherical IOL with negative spherical aberration. And if it's a hyperopic LASIK, go for traditional IOL with a positive spherical aberration. So these are the IOLs, spheric IOLs and spherical IOLs with negative and positive spherical aberration. The last step is step 4. In step 4, we have to compare the SIMK, total corneal power, and also look at the total corneal astigmatism. If all three are equal, then the patient is suitable for toric IOL. Otherwise, the outcome is unpredictable. So moving on to holiday report. This report is helpful in post LASIK or RK operated patient, especially where the anterior and posterior surface ratio is altered. EKR report is basically, it is not the net power of the cornea. In net power, the device measures, generally while calculating the net power, the device measures both the anterior and posterior corneal values and gives the total corneal power. But this value cannot be used in any normal variable IOL calculations like SRKT, Holiday 1 and Hoffer Q. So this report actually helps to avoid double correction while using this formulas. So in EKR, what happens is the anterior corneal values are adjusted or back calculated for any deviation of the back surface power from normal.
So,
So here
Dr.
in the
Priya, here for this, like this is similar to what the IL Master 700 gives as your, the corrected K readings. Like it gives you the anterior keratometry and then it gives the TK, right? So total
Yes, sir.
keratometry. However, the IL Master values of TK can be substituted for normal Ks in IL par calculations, whereas the ones which are derived from here should ideally not be used, right? As you said, that these cannot be substituted because they are
Yes, sir.
not
Yes.
meant to be used for IL par calculation. They are more important for kind of differentiating whether the total keratometry is kind of impacting surgery. So what I wanted to know was that would equivalent K readings here when would you know that they are abnormal, and when would you know that they are like within normal limits for a healthy cornea? Like, how would they be useful to us to understand that where the cornea is like showing something which is significant impact on total corneal power from the posterior cornea?
So, when you grossly look at the color maps, we can see the shape of the cornea. After refractive surgery, the maps kind of like they tend to show up some irregularities. That's how like we know that the cornea is very irregular, and we'll be looking at the holiday report and EKR report, which gives us better details than any other biometry.
No. So see, that's for refractive surgery eyes, for example, post RK and all, where
Okay.
EKR 65 becomes useful for some of our purposes. But what about regular corneas which are not operated or anything, and there can we utilize this kind of EKR 65 or the equivalent K readings? Because see, traditionally we don't measure posterior cornea, right? But
Yes, sir.
and we mainly go by anterior corneal measurements, and we assume that the posterior cornea is healthy. I was wondering that for normal eyes, like this one, what you're showing is probably a post LASIK eye because it's flat in the center, right? So, but I'm just wondering that if we were having a healthy normal eye, and there was some significant abnormality of the posterior corneal astigmatism, or posterior corneal measurements or keratometry, how would that look on these maps? I'm wondering, whether, I mean, when we were looking at it, how would we know that this is not a healthy posterior corneal measurement and this one is a healthy corneal measurement, for example? Like, how would you differentiate? I'm just thinking.
So maybe I'm just guessing that this report will also be useful to implant. I mean, for IOL implantation in keratoconus, because again in keratoconus we'll have altered. The surfaces will be irregular, so irregular that the ratio will be altered. So. Maybe in very irregular corneas after refractive surgery, and also in keratoconus, maybe this reports will be useful.
You're right. I think there it definitely would have a role in keratoconus as well. But anyway, I think this is some homework for us to kind of look up that in a normal person, like in non-operated eye, virgin eyes, if there is, how would you know on this report, on the holiday report, if a particular cornea had a abnormal posterior keratometry or a normal posterior keratometry, which was within the, kind of normative space. I think our time is going to finish in less than a minute, and I think we can log in again on the same link, right?
Okay, sir. Yes, sir.
Can we log into the same link when it closes? This meeting may stop any minute now. So we'll probably have to join back using the same link and the same meeting ID and everything as we had, isn't it?
Yes, sir. Same idea.
Okay,
Should
okay.
I
So
carry on? So then,
yeah, carry on. Yeah.
uh, so so in holiday EKR report, basically this report is different from holiday report in that it helps us to choose the corneal refractive power according.
Any thoughts so far, Dr. Chika? Like anything that you would like to comment upon amongst all? She's done a great job of presenting everything so far, and I think very nicely summed up most of the maps.
Yes, sir. I mean, actually, we tend to just on a day-to-day basis, for all practical purposes, we just look at mostly the quad maps and the Belin. So it's a good uh, refresher to, sort of all these maps that we tend to ignore most of the times. It's good to understand them better.
Yeah, actually, it gives us a lot of information which we can, if we just sit and play around with it, and for our, even for our cataract surgery and post-refractive surgery patients, and in many areas, I think lots to pick up from the Pentacam. And of course, it's very important for the purpose of our optometrists, who are also here. Biman, I can see, and maybe a few others were there. That it's very important for us to capture good maps, and we should know which maps are good and which are not. So the ability to recognize which are reliable and usable maps versus those which are not is also very important from our technician's point of view. So I think that would be important. So I don't know if others will be interested in joining back, but maybe we can start, Dr.
Okay.
So one
So,
more question.
Yeah.
Last what Dr. Tulsi had just explained, does that not give a too much of overlap with the eye trace findings as we try to look into eye trace, especially while planning for a cataract surgery? Like there quite some overlap. So I think maybe that is also one thing that we are trying to underutilize this, and maybe we are trying to find those loopholes through eye trace, which might be able to be fulfilled through Pentacam only.
What aspect, Dr. Amrita?
So like the angle kappa and the planning for the IOL calculation that was just mentioned, which we usually like even the cataract evaluation slides that were just covered. So usually we tend to see these things in eye trace also while planning through a cataract surgery. So does that really help?
Yeah, you're right. So,
That
the corneal part will be told very nicely on Pentacam, but the eye trace actually kind of goes beyond just the corneal. Eye trace has topography and aberrometry, whereas Pentacam has only corneal
only
topography, right?
topography
So
and the
here we will,
aberrometry.
sorry.
Yes, the same. I was saying.
Yeah, so the eye trace actually combines aberrometry and topography, whereas the Pentacam does topography derived from Scheimpflug images, but it also gives us like more like posterior corneal measurements, which the eye trace does not give us. Whereas this Pentacam does not give us the lenticular aberrations and the whole eye aberrations as good as what the
Yes,
eye
the
trace
eye
might
trace
give.
shows
So
on the
I
Chang
think each of them
analysis.
has their so each of them have their strong points. Pentacam is very strong when it comes to corneal measurements of every kind. And yes, of course, it does give you the angle kappa, but I don't know if it gives you the angle alpha. I'm not very sure. So, but angle kappa
I've
for
seen
sure it gives you. And
angle in cataract
yeah,
pre-op display. We have angle alpha 2, sir. But in Pentacam AXL, it's there. But I don't know. Like I haven't checked in our Pentacam basic and HR. But in AXL,
see again,
it
Pentacam
shows up.
AXL is a optical biometer, right? So obviously
Yes.
that would have more capability than the Pentacam. Pentacam AXL is basically Pentacam with optical biometry, right?
Yes.
So there it will include angle kappa and alpha, whereas just the Pentacam, which is for corneal applications, not for biometry, will probably not have that. So AXL is not widely available yet, and it is still kind of beginning to roll out.
So when I was going through the book on Pentacam oculizer, I came across this point that this map, Corneal power distribution map, is better map than EKR because it considers total corneal refractive power. Um, but EKR, holiday EKR actually depends on the true net power, which doesn't take the principal planes into consideration. So corneal total corneal refractive map, it takes into account along with the anterior corneal power, posterior corneal power, corneal thickness and refractive index. It also considers the principal planes. So when compared to EKR report, total corneal refractive power, corneal power distribution map is superior. So when we enter values from the according to the pupil size, when we enter the K values according to the pupil size into the ASCRS calculator, we generally choose values from this map. Where we have to select to the extreme right, as we can see to the top, we have to select ring, apex, and KM, and then choose the value from whichever zone we desire, like 4 mm or 4.5 mm, depending on the pupil size of the patient.
So I think that's nice. Can you just go back a moment to that slide?
Yes.
So here, while you said very correctly that we have to choose on the top right the ring, choose ring instead of zone, and choose apex instead of pupil, and choose KM instead of K1 and K2. And then you have to come down to this middle lower map and choose the you know optical zone from here. So if you look at the bottom, I think it says 3 millimeter optical zone, isn't it?
Yes, sir. Yes, sir.
Right at the bottom. So we have to change that to 4 because the ASCRS calculator accepts the value from 4, not from 3, right? And then you have to increase this to 4 and then pick up the, the value, because that will change the km from here, right? So basically we have to select 4 millimeter optical zone. After looking at the top 3 parameters, then you look at the 4 millimeter zone and then take the value from there. Am I correct?
Yes, sir. Correct.
Okay.
Also, we
And
can
then, of
just
course, can you tell us
look at
a
the
little bit
table.
about
Yes, sir.
yeah, okay, you can look at from the table also. But again, it's easy here because, you just select it and you will not go wrong in what you're picking up because it'll just show it to you correctly. Also, I was just thinking that, can you tell us a little bit about this map on the left side, the blue map, where, the spread is there from 43 to 45. How would it be different from a normal cornea to a post-refractive surgery cornea or something else? What says
So
as power distribution
this,
and selected
huh.
zone and
So this blue box, which is to the left bottom, it actually shows the range of the K values which are present on the cornea till the 8 mm zone from the center. So if the blue box or the blue bar is like widely spread, it indicates that there are like numerous values all around the cornea, which indicates an irregular cornea. If they are stacked up, it indicates it falls more towards the regular cornea. So here in post-refractive surgery, especially in post-RK patients, we do see a blue bar which is widely distributed from lowest range to highest range. The spread is more in post-RK patients when compared to normal regular corneas or post-LASIK patients.
absolutely correct. So let's go ahead.
So this is how we feed the values into the ASCRS web IOL calculator, and which generates a calculated IOL power. And this is the image of basic Pentacam HRA XL and XL wave. So in XL wave, we have uh, extra feature of IOL calculation user interface, and also provision to post record the surgeries. Uh, and also there is a feature to know about the scleral contact lens fitting features. And there are wide variety of formulas available in Pentacam AXL. These are the formulas which are available. And also in Pentacam XL, there is a provision for markerless toric IOL surgery similar to Virion and Callisto.
How does it
Jernical
interface with
analysis.
the microscope? I mean, if you take images on the Pentacam EXL, how will it, acha, with True Vision? Okay. So basically it will work on the Leica microscope with the True Vision system. I've used it before. So I think it's a good system. Okay. So what does it say here? Main application is for toric IOL planning. Fine. So it's basically very similar to what we do with Virion. So basically they have their own system.
So, and Pentacam also has features to detect corneal and internal aberration similar to iTrace, and which is represented as Jernick analysis in detail along with the values. And also, Pentacam XL helps, as I said, it helps in contact lens fitting, a variety of lenses like RGP, Rose K, and scleral lenses. Especially XL helps us to fit scleral lenses. This is the map which shows scleral lens fitting, as we can assess the coverage and elevation and profile of the lens.
But
So,
Dr. Tulsi, you require AXL for this, or you just, even on the normal Pentacam, if you have the software for contact lens fitting, maybe we can do it. I don't think we need AXL because there's no purpose of measuring axial length for contact lens fitting. This should require only the corneal fitting basically, and that is entirely possible on all Pentacams. So maybe we should just look up and on our Pentacam whether we have the contact lens software, and maybe we don't. And this is an optional software, I think, so which we didn't take because we didn't know whether it will be of much use to us. So like,
when
for
I
example,
click
we don't
that
have cataract
icon, yes.
densitometry.
Yes, sir. Yes, sir. We don't have. When I clicked on the contact lens fitting option, this screen didn't show up, so I thought it must be present in AXL.
No, no, AXL has nothing to do with it. It is available on the normal Pentacam also, but you have to purchase that optional software. So anyway, well,
The next feature available is iris image. We This actually helps us to measure white to white from the Pentacam and also match it with the digital calipers white to white measurements which we regularly do on in our clinics while planning for ICL implantation or IPCL implantation. So the last is ABCD display, which helps us to monitor keratoconus progression in case follow-ups are available, more than 3 follow-ups are available. And this is a graphical display where over time the values, the K values are compared with the normal and a keratoconic database is generated. And here, as we can see, A is nothing but it stands for anterior cornea, and B for posterior cornea, C for corneal thickness, and D for visual acuity. So, and the miscellaneous settings which are available in the Pentacam uh, or these where we can adjust the parameters like color map, scale, and zone appearance. And also we can change the preferred elevation reference shape to best fit a sphere or a BFTA, best fit toric ellipsoid. And also when you right click on the color scale, there is an option to select absolute or relative scale and the color steps also on the so absolute and normalized scale. Generally, absolute scale is used to screen for screening purposes, and relative scale or normalized scale is used for detailed examination. So, in our quad map, pachymetry and axial map are generally kept on absolute scale, and elevation maps are kept on relative scale. Thank you.
can you go back to the ABCD display, Dr. Tulsi, 1 minute?
Yes.
So here also, I think it's a very useful map. And if you look at the A for the anterior cornea, the B and the C and the D, it will give you gradings of A. It will select a baseline. For example, here you have to select the baseline. So you'll select obviously the 2012 one, which is the yellow bar. And you'll have to click on it as to be taken as the baseline. And if you have had any intervention, for example, if you did a cross-linking, you'll have to mention here that on which particular time you did a cross-linking, and that will, so see, if you look here bang in the middle, it says treatment. So you can kind of tell the Pentacam that when you did a treatment, and then it will show you the parameters as a curve, whether they are going, it's very easy. Suppose you have like 6 or 7 different maps here, and they can all be seen on one map itself. Suppose you've been doing Pentacam over the last 10 years and you've done it 6 or 7 times. It'll show all those 6 or 7 maps from the last 10 years on one page, just like the GPA, something like the glaucoma progression analysis, which we see on Humphreys, which kind of plots your fields, whether they are stable or getting better or worse. So same way here, it'll tell you whether the ectasia is getting, stable. Like for example, post CXL, it may show actually some improvement in the anterior curvature maps and not much change in the posterior curvature maps. But it may also show you compaction in the corneal pachymetry maps, and then later on it stabilizes. So it's very interesting to use this map, and it becomes a nice way to, because individually you will not open all the maps on Pentacam for various years. Like if you're seeing a patient today, you won't be able to sit and kind of go through all the maps over the last like 10 years. And if you have a post CXL patient, say 5, 6, 7 years post CXL, and you want to be sure that you're not missing a repeat progression or anything, then the ABCD map becomes really useful. Also, if you're following up a patient of keratoconus over a few years and you want to see how the patient is doing, this will show you over like 5, 6, 7, 8 years whether the cornea is remaining stable, and on all parameters, which means on corneal thickness, on anterior curvature maps, on posterior curvature maps, and also the vision. So D is very important because D you have to fill in yourself manually on each visit. Otherwise, it will not be useful since D will not be kind of showing up. So I think we should use this map more often for following up our keratoconus patients. Any other comments from anyone? Dr. Ruchika, Dr. Amrita, anybody else?
I think, sir, very nicely covered, like in detail. All the maps were covered nicely. So now maybe tomorrow onwards, I'll also make it a
I
habit to
agree.
go through all the other maps that we don't really look at.
I agree. So this was nicely done, Dr. Tulsi, and thank you so much for doing all that hard work of preparing for this session, and I'm sure it will be very useful. And maybe, Dr. Tulsi, I'll just suggest one thing. If you can also take this a smaller session like this for all our technicians and optometrists in the classroom in the rear. For
Sure, sir.
you can tailor it for their benefit, like how they will be able to use the Pentacam better than, I mean, from their perspective, how to use the Pentacam. It might be really nice.
Sir, I
Okay. And I'll request Dr. Amrita if she can prepare something similar on eye trace. That will be really nice for us if you can. So maybe we can divide eye trace into two parts. The cataract part, Dr. Amrita can prepare, and maybe the refractive part, Tulsi can prepare. Then it will become really nice. We can have two separate classes on how to use the eye trace better.
Yeah.
So actually taken, you were not there. We have discussed on ITRIS. I have the presentation with me ready, sir. So
Okay.
I'll
Does that include everything, like from refractive and cataract point of view?
almost everything. So like I'll search more, but it's a lengthy
So then
presentation.
take it, you go with that. You can prepare on iTrace, and we'll have Dr. Amrita prepare on something else. There's lots to do. So I think you prepare the iTrace one, and we can have that as the next meeting. Okay.
Yes.
And today, Dr. Ruchika, there was this interesting patient which I've told Tulsi to prepare for the dilemmas. Who had, which one was that, Dr. Tulsi?
She had squint
Where
also along
Oh,
with the
yeah,
steep
yeah.
gaze. She
Dr.
had
Ruchika, do you remember that patient with a large deviation and with, requiring refractive surgery with a high astigmatism? I don't know if you saw that patient or not. So anyway, we'll discuss that later. So I think enough for today, and thank you so much, everybody, for joining and sparing your time. So I think, can we log
So it
off,
was
everyone?
are you talking about the male patient? Large angle
No, there was a
squint.
girl who came with a large angle deviation, and she had a significant refractive error with significant astigmatism. And so we were trying to figure out whether, because see, if we do her refractive surgery first, the chances are that, post squint there may be some cyclotorsion, and we may not be able to give her a full correction anyway on the, because of the high astigmatism. So we were wondering whether that would cause any problems. And maybe, we thought that if we do the squint first and allow things to stabilize and then do a refractive surgery. So it was a dilemma which one to do first. Very often we kind of say that we could do either first, it doesn't matter. But for that particular patient with high astigmatism, I was wondering whether what will be a better idea. So she did have not only a large angle deviation, but also a little bit of vertical deviation.
Oh,
But each eye was individually correctable to 6/6 with glasses.
okay. I
So
remember,
we
so there
can
was
maybe,
this
think.
other male patient. You did a smile for that guy, and he
Yes,
had,
whom we counseled a lot about his problems. Yes.
yeah, he had, it was an intermittent squint, but it was very large angle. Like he would
Right,
break into
right.
a squint, and then he had such
I
good
remember
control
that.
that like he would become
Yes.
ortho.
And he
Like,
was refused to believe that he has a squint. So I had to actually call his wife and, convince him that he has a large angle squint.
yeah,
And the
he
best
had,
part was that, to convince him, I tried to make a small video of him, and whenever I would try to make a video, he would be able to fuse. So I
yeah,
couldn't capture his large angle deviation because he would start looking into the camera, and then, he was able to fuse. So every time I tried to record it to show him that, you have a large angle, he was able to control it, and I couldn't kind of, record him with his large angle deviation. But post surgery, he actually did well. I've put him on convergence exercises. He's actually got lesser manifestation of his exotropia than he was having before somehow, which is surprising because most often it becomes worse.
Actually, I had never seen such a large angle intermittent squint. I mean, uh,
I agree.
normally it at some point it actually seems like a very like apparent exotropia, but he had very good control. I
Absolutely.
don't know
In
how.
fact, I
Yeah.
counseled him that he's probably going to need squint surgery down the line. I told him that if your fusion breaks and you're not able to kind of fuse subsequently, you may need to go straight away for a squint surgery as well. And in that sense, I was happier to do a smile for him because, then doing a squint would not require us to wait for a very long time because there's no flap, so you could
Right,
actually
right,
proceed with squint surgery whenever you want. So that's
right.
another
So,
thing. Chalo, great. So
okay.
good class. Thank you, everybody. And
Thank you.
good night to all of you. Thank you.
Yeah. Thanks, Tulsi. Yeah. Good night.
Thank you.